right, so our second session is going to be talking about hepatic EHE treatment approaches. We're going to have two speakers. Our first speaker will be Dr. Thiels from the Mayo Clinic, who is a transplantation specialist and surgical oncologist. Our second speaker will be Dr. Raj from the Miami Cancer Institute, talking about interventional oncology. And we have Dr. Thiels present, so let's have you take over and let's hear what you have to say about transplantation.
Yeah, thanks so much. So a disclaimer, I'm definitely not a transplant surgeon. I'm a surgical oncologist and HPB surgeon. We work closely with our transplant colleagues here at Mayo in Rochester, and actually all the Mayo sites have both kind of HPB surgical oncology and transplant. But I will talk about our transplant experience a little bit with the caveat that I'm not a transplant surgeon, although I appreciate the promotion. So I'm a surgeon here in Rochester. I specialize in sarcoma surgery, and I was asked to kind of share kind of our experience, and that largely comes from a historical publication, then a more recent publication that one of our research fellows just put together, kind of looking at our experience with hepatic EHE. Let me just close that so I can see. I have a few disclosures, but none are relevant to this talk, in my opinion, and nothing related to undisclosed pharmaceuticals that are used off-label necessarily. So when it comes to liver-directed therapies in the kind of modern era, there's a lot of options, and these are increasing almost every day. This can range from traditionally surgery, which is still obviously an option and frequently can be used for liver tumors. Cryoablation or radiofrequency ablation, less commonly utilized, but in some more benign behaving tumors, cryoablation can still be utilized. Microwave ablation, definitely a tool. I think we'll hear about this a little bit in the next talk too. IRE, which is being used more and more in place of microwave, or really, at least for us, we use it when maybe it's a better option than microwave ablation in unique situations. We do occasionally use radiation for hepatic EHE. We use it quite a bit for other tumors in the liver. And it can be a great treatment option for liver tumors, particularly small ones, or sometimes in a palliative setting. Usually for EHE, we use it more in kind of the palliative setting. I'll talk about that. Y90 and transarterial therapies, maybe the next speaker can comment on this. I have not recommended or seen this used for EHE, but is used for other liver tumors. I thought, it's not really a liver-directed therapy, but it is probably one of the most important liver-directed treatments in this scenario is observation. Transplant, absolutely, and we'll talk about that. Hepatic artery infusion pump chemotherapy has not been, to my knowledge, ever utilized in EHE, but also liver-directed therapy. And then histotripsy, which I'll briefly touch on because a lot of patients have questions on this, but potentially a future treatment option in some situations. So the bold ones here are ones that we will commonly utilize or have utilized, maybe radiofrequency ablation being the least common one for hepatic EHE. And so we'll talk about a couple of these. So I'll briefly introduce kind of some of these more common treatment options, and I'll talk about some of kind of our experience with it. So when it comes to surgical resection, there's really kind of two ways to do this. One is the traditional open surgery, which nowadays looks nothing like this original picture of surgery at Mayo from a long time ago, but is still utilized. And the second is minimally invasive surgery, which can be done both laparoscopically and robotically. Really, the difference is just the tools that we use to do the surgery. Otherwise, it's really the same operation, both open and minimally invasive. However, when it comes to liver surgery, the minimally invasive liver surgery does potentially have some significant benefits in some cases, although it's the same surgery on the inside. And here you can see just a robotic surgery kind of in action. What really matters in some ways more than the approach to the surgery is the type of liver surgery that's done. And all liver surgery is not the same. It's a huge variety of what that really means. And it can mean everything from a parenchymal sparing or liver sparing, very minor resection, sometimes done minimally invasively, with very limited, sometimes even just a one-night hospital stay, no recovery, and in our experience, very low risk, less than 1 or 2% risk of a major life-threatening problem, to much more major resections, resecting large amounts of liver. Luckily, the liver can regenerate, but those still have life-threatening consequences and can be very major resections. And that's, while less commonly done for hepatic EHE, can in some situations be done, and that's a very different surgery. We also have surgical ablation, which is sometimes utilized in combination with surgery, meaning we'll talk about a couple different treatment options, but not all these treatment options are one or the other. We sometimes do combinations where we actually do ablation during the surgery, where some tumors can't be ablated and removed, and some tumors are actually better treated with ablation, and we do that quite frequently here. The hospital stay can highly vary, anywhere from 1 to 5+ days, really depending on the tumors mostly and what needs to be done. And recovery is typically 4 to 6 weeks from liver surgery, sometimes a little less. Obviously, if complications come up or it's a major surgery, then it can get quite a bit longer sometimes. But oftentimes with a more minor liver surgery, we do expect patients to hopefully get back to a pretty close to normal or excellent quality of life long term for the more minor ones. And again, as I talked about, that risk really depends on the extent of the liver resection more than anything. When it comes to ablation, and I probably will go through this a little quicker given the next speaker, there's many different types. We very rarely, but occasionally utilize cryoablation in this situation. We do commonly utilize microwave ablation or in some situations IRE. IRE, in our experience, is best utilized when there's involvement of vessels that we want to preserve in the liver to try to more safely treat something, but it can be utilized in other situations as well. And really, what I want to point out is this can be done in many different ways. Sometimes it's combined with open surgery, minimally invasive surgery, or percutaneously when there's only one tumor and it's a good location, or a couple tumors, or sometimes even more than that. It can be a great option. We typically recommend this for small tumors, kind of 2 to 3 centimeters in size. It depends on their location is the big factor. And for these small tumors, I think there's growing and great data to support that it's probably equally as good as surgery for small tumors. For big tumors, there's not as much data for that. Not that it can't be done in some situations, but a little less data. And then for a lot of tumors, sometimes we'll do kind of more of a combination approach, but still can be used. Radiation, including SBRT is just one term people use, is occasionally used. We pretty rarely use it for hepatic EHE. It can be used in the palliative situation or in place of surgery or ablation. I mean, it can work pretty well in some situations and work much like a surgery or like an ablation, which can have a similar outcome. It's typically good for kind of a single or two small tumors, not ideal if you have a lot of tumors. And again, sometimes used for palliation, actually more of bone metastasis and things like that in our experience. This is a picture of proton beam radiation. Actually, in the liver, we tend to not use that as often because it doesn't make as much sense, because you want to have a border around the tumor where you miss a little bit to kind of treat that whole area. So it's not that you want to miss and hit other parts of the body, but you actually want to miss by a couple millimeters, and so you don't need that millimeter precision. So while we have a lot of proton therapy here, I would say it's less commonly utilized in the liver just because it actually isn't necessarily always helpful. And then transplant. I think transplant is something we sometimes definitely utilize. I'll talk about our data for that. This is a major surgery. This is not a one-time event is the big difference here. Not that surgery or other treatments are always a one-time event, but this is really something that requires months or sometimes years of workup, lifelong medications. And it's a big, risky surgery, but it also can be incredibly life-saving, especially when there's extensive disease, or really primarily when there's extensive disease, liver failure from tumors, things like that. And this is really kind of in a way, a lifelong commitment and a huge team, but probably can be one of the most life-saving treatments here for some patients. And then I wanted to briefly mention this because I think patients have a lot of questions about this. This is histotripsy. So this is a treatment that actually uses ultrasound to treat tumors and doesn't penetrate the skin at all. So there's actually no needles, no surgery. You do have to be fully under anesthesia for it. But it, in theory, can treat tumors, and it was approved in very late or kind of early 2024. But there's really no data for it. It uses kind of this non-invasive technique under full general anesthesia, and this is from the company, not in a human, where they show that you can kind of create an outline of a tumor, meaning you can really precisely treat something, which has incredible potential. And so I think this is an exciting technology that kind of can destroy tumor cells. The problem is it actually is fairly limited in where it can reach right now. I suspect that might get better, but is still a big limitation. And then the big limitation is right now we have zero data, in my opinion, for almost any cancer. Actually, we have no data, but definitely not for EHE. And while we may not get enough data for EHE before we start using this, and I suspect we will use it, I think it's really important that we have data for other cancers to show that this is safe and it works. We have that safety data, but we don't have the data saying it works yet. So we tend to only recommend this on trial, and we offer it here at Mayo, and we'll have a trial opening soon for some patients for this who aren't candidates for other treatments. Meaning if we have other treatments we know can work, we typically won't recommend something experimental unless we do it on trial, because we don't want to put a patient through something that looks and sounds amazing, but maybe doesn't necessarily work, because unfortunately sometimes in medicine, things that look and sound good don't always work. So with that, after kind of introducing the different types of treatments, I was asked to kind of talk about our experience here a little bit. And so I'll talk about kind of surgical resection, ablation, and transplant, really from 1984 to 2023 plus. This really comes from two papers that we've published, one in 2010, one recently last year, published by one of our research fellows, Teddy Salma, did a great job kind of diving into all the details and trying to get in the nuances here of the data, looking through kind of our experience. We were able to identify 80 patients with hepatic EHE. The big caveat here is that we treat a lot of patients around the country and around the world who come here for sometimes only one opinion and don't necessarily get long-term follow-up here at Mayo. So not all of those patients were captured where we just did a review of their biopsy or a one-time kind of capture of them. These are more patients that ended up coming back here multiple times, being treated here at Mayo, and there's definitely some bias in terms of who that is, who stays at Mayo for treatment versus goes back home. But in those patients that we were able to kind of follow and have some data for, about 26 underwent liver resection, 24 underwent liver transplant, and 30 were treated medically. Now, I want to kind of give a big caveat here. If you look at the patients who were treated with just observation or medications, these are very different patients than the patients who had surgery or transplant. These patients had a lot of extrahepatic disease, 70% of extrahepatic disease, and actually 20% had bone metastasis. And I point that out because that'll be important in a minute when we kind of go through this. And so these were very different patients than the patients who had surgery. So you really can't compare how patients in this group did to those that have a liver transplant or surgery. But since we have such limited data in this scenario, we wanted to kind of at least publish all our data, because I would argue some data is better than no data. So big caveat, these are very different groups of patients. You can't say that surgery is better than observation with this at all. Observation is an absolutely critical component here, and you also can't comment on that transplant is better necessarily, because these are, again, very different groups, but wanted to kind of highlight kind of what we've seen. If you look across the board, most patients were slightly more female, 62%. The median age was 44, with majority of patients being between 33 and 59. About half of patients were symptomatic, actually, about 60%. Most patients had no history of liver diseases or anything like that. And obviously, all of these patients had liver tumors because that's where the disease was kind of primarily based. Again, looking at these different groups, this just highlights how different these groups are. The patients in the resection and transplant group, while some had disease outside of the liver, the vast majority didn't, versus a lot of patients in the non-surgical group had disease outside of the liver. We did try to look at what treatments the patients had gotten who didn't have surgery or transplant. And what you'll see is that this is obviously over a long period of time, but there was a lot of different medications tried. Dr. Robinson, kind of our world expert here for us at Mayo at least, can comment on this a little more about the different medications. We saw some patients who had long-term stability occasionally, but a lot had pretty quick progression on medications, probably a lot more representative of the biology than anything else. But obviously, these are also patients who've already had progression of disease in many places. Most of them did not have just one or two tumors and relatively stable disease. The reason they went on these medications is because they were having tumors that were growing and spreading. Overall, though, when we looked at all of these patients did remarkably well. We weren't able to be successful for everybody, but a lot of patients did really well. And about 70% were still alive at 10 years. At kind of the maximum follow-up we were able to get. This number gets small because we don't have people that far out who follow up at Mayo Clinic. But overall, what's reassuring is that we're seeing this curve flatten in terms of hopefully seeing people who are alive for quite a long time across all of these groups. Now, this was very different when you look at the patients who had no surgery in red or just medical treatments or observation versus resection and transplant. Again, though, these are not the same. So you can't say that patients who get transplant or resection do better than surgery. Just the ones we end up selecting for resection or transplant do better, with a quite good kind of 80% survival long-term that, again, plateaus as well. We then looked at comparing kind of transplant and surgery, and the first thing I'll point out is that these are very different groups of patients as well. About half were symptomatic, but the surgical patients had much smaller tumors and less likely to have tumors involving both sides of the liver versus transplant patients had larger tumors and usually involving both sides of the liver. Same, they also had more tumors in more parts of the liver, meaning almost all the transplant patients had tumors in multiple segments of the liver. They almost always had greater than 10 tumors, with the ones who didn't have greater than 10 tumors typically had larger tumors on both sides. And a lot of them had a lot of tumors. So this is the median number of tumors in the liver. The transplant group had 31 tumors throughout the liver. So you can see the patients we select for transplant have a lot of tumors in the liver versus the ones who have surgery tend to have very few, less than 10 for sure. The median number was 4. We did have patients who had disease outside of the liver in both groups, not commonly, but a few patients. And then some patients in the surgery group had bone metastasis. I'll talk about that in a minute. Here, looking at the outcomes a little bit of the liver resection versus transplant, we were able to remove all the tumors in 96%, 25 out of 26 patients in the surgery group. Transplant is the ultimate surgery. You remove the whole liver, so 100% of tumors are always removed in that standpoint. But actually, interestingly, in both groups, both the transplant who had a new liver and the surgery patients, the chance of having a tumor come back in the liver was about 1 in 3, 33 or 38% in both groups. And often those tumors came back in about a year, so 9 months versus 1.5 years or so, or maybe 11 months, sorry, versus 1.5 years or so in both groups. And they often went on to get other treatments at that point. Looking at these two groups a little further, again, we were able to get 25 out of 26 patients have all their tumors removed. About a third of patients had a recurrence. Interestingly, there were 2 patients who had surgery who had bone metastasis, and both unfortunately did very poorly and progressed very quickly and passed away soon after surgery. But actually, none of the patients who had disease outside of the liver and the bones, meaning if they had lung metastasis or peritoneal or otherwise, they all did very well. So those with extrahepatic soft tissue metastasis, none of those patients died by last follow-up, and they all had stable disease, meaning the disease outside of the liver that wasn't resected or treated actually remained stable, which I think is an important point. We don't know if the liver would have stayed stable because we took it out, right? So that's a big limitation. If we look at the transplant patients, the other thing that I want to point out is they not only had a lot of tumors, but actually over half of them had liver failure at the time of surgery, which was one of the reasons to go to transplantations, or the reason. Again, similar number had a recurrence a little further out. And these patients did very well, just like the transplant group. The median survival was actually 16 years, again, with no difference in terms of the patients who had disease outside of the liver versus not. So no difference in kind of survival in those two groups. We then looked at those patients who had disease outside of the liver versus not. And again, we showed that definitely the patients who had disease outside of the liver didn't live as long as the ones who didn't. But when we kind of stratified that further by where the disease was, what we saw is that the bone lesions tended to be the patients that had the most trouble with progression of tumor, not the other sites like the lung. And I'll point that out a little further here. You can see here, these are patients with bone metastasis who have much, unfortunately, lower survival versus those with lung metastasis or other places do almost or equally as well as those who have no spread outside of the liver at all. Meaning lung metastasis actually maybe doesn't drive the biology at all in terms of how people do long term. Here, this is then adjusted for using as many factors that we could kind of adjust for given the relevant factors. But you can clearly see here that when you control for other things like age and what we did, that bone metastasis had the highest hazard ratio for mortality in this study, being the most kind of thing we should probably be most cautious about. So in terms of overall findings, we definitely saw that bone metastasis was at least associated with a lower survival. We saw that lung metastasis had a much better survival compared to those bone metastasis. At least on the univariate analysis, we saw that surgical resection may improve survival, but this is not necessarily significant when you adjust for age or bone metastasis. And again, these are very different patients, and we're really just kind of selecting out patients with a biology that maybe will do well. So I actually can't say that surgery helps people necessarily in that situation. But we do think that risk stratification in terms of who gets transplant or surgery needs to consider particularly bone metastasis in is this going to help someone? Does it make sense? And I think the biggest thing here is that not all surgery is the same. A very minor liver surgery or a percutaneous ablation is very different than a transplant. And it really depends on what we're talking about doing in terms of the risk benefit, not just yes or no, is surgery helpful. So kind of our approach here, I'll summarize a little bit, is that there's clearly no one size fits all when it comes to hepatic EHE. Every case is very unique. Every patient here meets with medical oncology, an HPB surgical oncologist. We engage radiology, interventional radiology for other treatments as well. Same with radiation, because definitely there's a very nuanced approach here. And with that, the same thing goes in terms of each unique patient's biology. The bone metastasis for liver EHE seems to make a difference, although this is not a one size fits all either. And that's where obviously figuring out that biology is incredibly important. And we can't really tease out observation in this data because you need an intent to treat and a prospective trial to really understand that. A retrospective study like this one really can't get at the benefit of that or when we should do these treatments. And we don't know yet the benefit of surgery or early transplant. Clearly, transplant at some point can be very beneficial for some patients, though. Our kind of approach, though, in summary, is that patients with resectable liver tumors, we often recommend resection and definitely not typically systemic therapies. This is typically patients with less than 10 tumors. Lung metastases are usually completely okay. We will test the biology over time, but sometimes we definitely operate on these patients. We definitely have pause now with bone metastasis. Not in every single case. There are unique cases where these can remain very stable with time, but this is definitely where at least I'm much more skeptical that I really want to see kind of how this disease is going to behave. And we almost always test the biology before surgery, but this is really where it depends. If you have one single tumor we can resect or ablate with an outpatient or a one-day stay surgery, then it might make sense to kind of just remove that and take it off the table early versus a major surgery or transplant is a very different thing to consider. And in patients with unresectable liver tumors, we do consider transplantation. This is almost always more than 10 tumors, usually more than 20 or 30 tumors. Some have liver failure even by that point. And while non-bony metastasis is okay, I think we kind of with this data are a little concerned about considering transplant somebody with a bony metastasis and certainly don't rush to transplant either way. So I think we'll move, if I understood correctly, on to the next talk, but happy to answer questions at the end, I believe. And I really appreciate the privilege of really coming to this group. I'm excited to work with this organization more. It's a privilege to kind of meet and be here.
Oh, thank you so much. This is a wealth of information we didn't have a few years ago. And I know the patients really appreciate the level of study and work that goes into analyzing all of this to help make better decisions. So yeah, please feel free to step back for now. We'll have you come back for the Q&A after Dr. Raj's talk. And let's turn it over to Dr. Raj.
Thank you. Good morning. Can you hear me?
Your audio is great.
Okay, great. Good morning, everyone. Thank you very much for having me speak. It's an honor to speak to all of you. My last name is Narayanan. I'm from the Miami Cancer Institute, and I work at the Miami Cardiac and Vascular Institute. I'm an interventional radiologist. My main focus is oncology, and I treat mostly primary and metastatic liver tumors. Happen to and get involved with HEHE by chance. One of the members of the HEHE community, her son was involved, had the disease, and they reached out to me for potential for IRE, and this was several years ago. At that time, there was only one case report that was published by Dr. Ken Thompson in Australia, where they treated one patient with HEHE. And so that's where it started. We started out with the first patient, and we treated that patient for multiple lesions, which all responded really well, which then got me more involved with the patients who have liver involvement with HEHE. So I'm going to share with you a little bit about IRE and our experience and our most recently published paper about the role of IRE in the treatment of HEHE. So as we all know, it's a rare malignancy, and the incidence is about 1 to 2 per million people. It can resemble benign hemangioma or multiple aggressive coalescent lesions in the liver, usually younger patients, 20 to 40 years old. And these are some of the findings which we typically see on CT and MR, where the lesions are more pronounced on the venous face than the arterial face. And then they have this typical halo appearance in MRI, targetoid appearance, which we look for. And typically when we see these lesions next to each other, and as they start getting bigger, and they tend to coalesce and become a bigger tumor. So the characteristics, it follows the pre-existing vessels along the sinusoids and through hepatic veins. Neoplastic cells are observed in sinusoids at a distance from the tumor foci, and the intravenous growth in the form of polypoid tufts is noted in a majority of the cases. So multifocal growth seen early in the disease due to perivascular involvement, and here's just a pathology showing the coalescence of the confluent tumor masses. Treatment options, surgery has been commonly used in patients who are candidates for hepatic resection. Previous speaker spoke about liver transplantation also. This is another option for patients. Of course, liver transplantation carries with the fact that they will be on lifelong immunosuppression. However, it gives the option of having a new liver without disease involvement, of course, chemotherapy, radiotherapy, and chemo and radioembolization. Radioembolization has been sporadically used in some cases, but in our institution, we've even though we do extensive amount of radioembolization for other pathologies, I've pretty much used a needle-based approach with treatment of HEHE. Microwave, RFA, IRE, these are different ablative tools that are available in cryo. So microwave, RFA use heat and they burn the tumor, and cryo freezes the tumor. These three are considered as a thermal ablative technique. The difference, we're going to look at IRE a little more in detail. With microwave, RFA, and cryo, with thermal ablation, the tumors undergo coagulative necrosis, fibrosis, and scarring. And typically the healing is just, it becomes a scar, and you really don't see much of a size decrease over time. And so switching gears to IRE, which is considered a non-thermal ablative technique, and this can be used both in the open setting in the OR or can be done percutaneously with imaging guidance. So the fundamental concept is that you're exposing the cell to electrical current. And this technique has been around for several decades as a reversible electroporation. And when the energy applied is about 1,000 volts, you create pores in the cell membrane, and these pores are reversible. And so this has been used to introduce genetic material, proteins, and even for electrochemotherapy, which is still in use in Europe, where you can cause a disruption of the cell membrane and use that temporary phase to get these materials into the cell. The scientists at UC Berkeley working with this technology found that when they increase the voltage systemically to from 1,000 volts to 3,000 volts, that the pores in the cell membrane were permanent and led to destruction of the tumor cell even without the addition of chemotherapy. And that led to the birth of irreversible electroporation, which was then commercialized but as the nano knife. Even though there's no knife involved, that's the clinical, that's the commercial name for the device. So irreversible electroporation uses a high voltage, low energy DC current. So you have a positive and a negative, and anytime you turn the machine on and deliver the electricity, it's going to cause these permanent pores in the cell membrane. In the early studies in Australia, they found that patients were prone to cardiac arrhythmias given the amount of energy that was delivered, which got this device now to become a part of the whole setup. This is called the AccuSync device. This is gated to the patient's EKG. The role of the AccuSync device is to detect the rising slope of the R wave in the patient's cardiac cycle. And when it detects that, it sends a signal to the nanoknife machine, and the energy pulse is delivered to during the refractory part of the cardiac cycle, and skipping the vulnerable phase, and thereby reducing or eliminating the risk of cardiac arrhythmias. So how is IRE different from the other techniques that are out there? So it's predominantly non-thermal, and it spares the collagenous skeleton. You have an intact adventitian lamina that is visible at 2 days with no smooth muscle cells present, and these are repopulated at 2 weeks. the endothelium in the intima is largely repopulates at 2 days. And since the collagenous skeleton or scaffolding of the blood vessel is intact, you're able to place needles in very close proximity to blood vessels and other critical structures and not damage them while you're able to completely kill the tumor, which is in between these needles. So this is the commercially available device with the touchscreen monitor. These are the monopolar electrodes. You need at least 2 of them to create a treatment zone, a positive and a negative, and you can use up to 6 depending on the size of the tumor that you are treating. And here's the AccuSync device. The interface is also different from thermal ablative techniques. You have a touchscreen monitor, and the right you see an animation of the tumor and the needle placements. So assuming we have placed 4 needles, we can now program the energy to be delivered between these. At any given time, the pulses are delivered only between 2 needles, a positive and a negative. So you can use even number of probes or odd number of probes. It does not matter. And you can program the energy to be delivered just across the needles from one to the other, or you can also add the energy to go across, for example, here between 1 and 4 and 2 and 3. On the lower left is the depiction. The yellow circle is the tumor, and the numbers are where the needles are placed. This light blue is the head of the patient, and the light blue around the yellow is the estimated margin that we're going to get. Just like surgery, we also want to get a margin when we're treating the tumor, get part of the normal liver to be treated. The maximum energy that can be delivered is 3,000 volts between two needles, and the maximum voltage per centimeter is 1500. So even though here you're seeing that the distance between the 2 needles is 2.2, the maximum energy is only 3,000. So that does not go more than 3,000. We need 70 pulses to create a treatment zone. And if you're using only 2 needles to treat a small tumor, then the actual treatment time is only 70 seconds. Of course, there's a lot of preparation. The procedure can only be done under general anesthesia and complete muscle relaxation. So patient has to be under anesthesia. So we do all our procedures with CAT scan guidance. So once you have everything set up and you turn the machine on, here now you have 70 pulses being delivered between probes 1 and 4. And then the machine automatically switches to the next pair. It's 2 and 3, 2 and 4, 3 and 1, 3 and 4, and 1 and 2. And that's how it completes a complex treatment zone. This is the 3rd generation device. One of the advantages of this is that we can now watch the electroporation live in real time. In the past, we had to wait for the study treatment to be completed and go back to analyze this graph. So what does this graph tell us? While we're delivering energy, these are packets of 10 pulses. You want to see an upward slope in this graph. What that tells us is that the cells are electroporated and now more energy is being delivered into the cell. That's the measured with the amperage. So if you start at say 20, you want to see at least a bump up to 35 or 15 amp delta while the treatment is going on for us to know that that particular pair has completed treatment. Some of the indications for IRE, typically we use it for tumors that are less than 3 centimeters, but size is not an absolute criteria. There are tumors which are much larger than 3 centimeters that we have treated. Lesions which are not amenable to thermal ablations, anything that is close to critical structures, so near veins, arteries, biliary ducts, and if you have the colon, kidney, any of them in close proximity to the liver, you don't have to push them away or separate them like you would have to do with thermal ablation. And also, the technique is not susceptible to heat sink, which happens when you use a thermal ablation. Anytime you treat a tumor near a blood vessel with the thermal ablation, the flowing blood in that vessel can steal some of the heat. So part of the tumor that is in close proximity to the vessel will not be appropriately treated. That's called the heat sink. So some of the contraindications, anyone who cannot undergo general anesthesia, patients with a history of significant cardiac arrhythmias, pacemakers and ICDs, and patients with a history of seizure disorders or uncorrectable coagulopathy. So this is just a short clip of the actual treatment. Even with complete muscle relaxation and general anesthesia, you're going to see some movement in the needles. This is expected. and that's normal. But also something totally different from the other ablative techniques where you're not going to see this movement in the needles. This was from the EHE study published by Professor Thompson, the one patient that they had. And so after several years, given the rarity of this disease, we were able to collect a good number of patients and have our first publication in one of our main journals, the CVIR journal, which is the Cardiovascular and Interventional Radiology Society of Europe. And we published our results using IRE as a treatment in HEHE. This was a retrospective study of 14 patients who had 47 HEHE tumors that were treated with IRE in 23 CT-guided procedures between December 2017 and August 23. Sorry, there's a typo. This is 2 centers. One patient was also included from Europe in the UK. Primary and secondary outcomes, we look for safety and effectiveness, and secondary outcomes were technical success. We wanted to know if we could get a complete ablation with the margin greater than 5 millimeters. We looked at post-treatment tumor sizes and length of hospital stay. The procedure was technically successful in all tumors, and following a median follow-up of 15 months, 30 of these demonstrated a complete response using modified RECIST criteria. So this is a criteria that we use for percutaneous image-guided ablations in any tumor that enhances with contrast. So anything which completely loses the enhancement of with contrast after the ablation, that's considered to be a complete response. Anything with 30% residual contrast enhancement considered a partial, and anything which continues to enhance would be a failure of treatment. So the average tumor size pre-treatment was 25.8 millimeters, accompanied by an average reduction in the tumor size of 7.5 millimeters. In 38 of the 47 tumors treated, there was no evidence of local recurrence. In 9 tumors, residual tumor was present, and these were retreated. The median length of hospital stay was 1 day, and only 1 grade 3 CTCA event occurred, which was a pneumothorax that required a chest tube placement. So we concluded that the study shows that IRE is a safe and efficacious method, a minimally invasive treatment option for HEHE. Again, for colorectal mets or HCC, there's a mountain of data out there, given the number of patients that have been treated with the different modalities in the publication. But even with this small number, this is the largest series we can see with where ablation or IRE has been used to treat HEHE. So here's an example of a lesion, which you can see a short clipping on the right and a static image on the left. This was treated with 3 needles. These were placed in a triangular configuration. You can see there 1 is in the superior part of it, and 2 of them are placed in the widest part of the tumor. So once the needles are in place, we do what's called a 3D reconstruction to measure the actual distance between the needles. We want them to be no more than 2.2 centimeters. It can be less, but we don't want it more than 2.2 so that we avoid skip areas. So this was the follow-up of the same patient at 238 days with no evidence of local recurrence in that area. Just to show you the healing mechanism also, we talked about coagulative necrosis, fibrosis, and scarring with thermal ablation, which is why I don't use it in this particular pathology. So here is a patient in 2020. This large area was treated with IRE, and the same area in follow-up scans now in 2025. Patient also had a huge area involvement in segment 6, pretty much occupying almost most of the segment in close proximity to the colon. And this was also treated, and here we are 5 years later, where you can barely see the area that was treated. So that's one of the advantages we feel with IRE in using that in the treatment of HEHE. So in summary, this was the largest ablative human experience where we've used it using IRE in the treatment of HEHE. And IRE is uniquely able to treat these vascular lesions safely, and it's a viable alternative or to prolong liver transplantation in patients with multifocal diseases. We've had several of these patients who do have multifocal disease. So thank you very much for the opportunity.
Thank you so much. And if I can call our panel members back for a Q&A session here, we have quite a few questions that came in. And we also have a guest panelist, Dr. Robinson, who is an oncologist at the Mayo Clinic. And I've got two clarification questions. I'm going to send the first to Dr. Robinson, if that's okay. We've got a question about what is the terminology difference between EHE and HEHE in terms of the hepatic? How should we understand those? Is the same or different?
Thanks. I want to start by saying thanks to the panel for having me. Hope you guys can hear me clearly. I'm in a hotel room in Boulder.
Excellent.
Yeah, and so I think the primary focus here is the issue here is like what is the origin of the tumor? Where is it starting? If it's primarily hepatic origin, then we're going to call it hepatic EHE. And if the primary is arising elsewhere, then it's essentially epithelial. He mentioned epithelioma, but where is the disease arising from? Where's the focus?
Excellent. Okay. So if it originated somewhere else and metastasized to the liver, it would not be called HEHE?
I mean, it's still hepatically involved, right? But I think for the purpose of taking care of my patients, just to distinctly, know to this, for example, in angiosarcoma, we can see it arise in the liver. It's a primary, angiosarcoma in the liver. Should it arise in the extremity and metastasize to the liver, the liver is still involved, but it was originally primarily in the thigh.
Thank you. And I've got a clarification question for Dr. Thiels. You'd mentioned a few times, especially when we were talking about METs outside of the liver, you talked about testing the biology on those. Could you describe a little bit more detail about what kind of test that is and what you're looking at?
Yeah, sorry, there's some background audio, should stop soon. But yeah, no, thanks. Great question. Sorry. So really what that means, I think, for us is trying to figure out how each patient's tumor is going to respond to ideally what we do. That's really hard, obviously. But a lot of times what we can do is figure out how it responds to doing nothing, right? Because we do know that there's patients who can have tumors not change for a long period of time, years and years or longer. And so that's where we like to try to figure out how can we best do an educated guess of how that's going to respond based on a shorter amount of time. Now, obviously, if it keeps staying stable, we can continue that for long periods of time. The biggest risk, obviously, though, is that the only way to know that that isn't working is that when the tumors then grow and spread, and then we may lose a treatment window or a treatment option. So that's where it gets really hard is, yes, in an ideal world, we would watch everybody's tumors for 20 years and then go back 19 or 15 or 10 or 3 years prior to decide what to do. Since we have no way of doing that, we usually do it for less and then kind of see and hope that we can catch changes before they become clinically significant. So yeah, it's kind of where we watch how the tumors do over time and hopefully not change. It just that isn't obviously as easy as it, we would like it to be.
Is that mostly done with imaging at this point?
Yeah, it's mostly done with, that's just surveillance or observation where we just check initially every 3 months, then spread it every 6, and sometimes eventually every 12 months, depending on how the tumor is behaving, because we definitely see tumors behave very differently. And I think we're hopefully going to in the future have ways to determine that, maybe off the biopsy, right, would be ideal. But that's where there's still a ways to go, or off imaging maybe one day to figure that out without having to wait and see.
Question for Dr. Raj. We've heard about a lot of different ablation type techniques, microwave, radiofrequency, cryo, IRE, and then the histotripsy. What kind of thoughts go into selecting which is the right one for which patient? And are you, in your own sort of thoughts and practice, do you have a preference for one over the other where two or more might be available as an option? Like what's the calculus for that?
Yeah, we have all the modalities that you mentioned. We use microwave routinely. Probably that's like a workhorse. Cryo, we use it in mostly renal cell carcinoma and treating metastatic lung tumors and soft tissue metastases and for pain palliation. Histotripsy is the new kid on the block, and we were part of the Hope for Liver study, which got the technology approved by the FDA. We treated 2 patients in that study. One of them was a HEHE patient. So the advantage of that technology is that it is completely non-invasive, where there's no needles, but there are some limitations, mainly the tumor has to be visualized under ultrasound, and there needs to be a window for the ultrasound beam to be to target the tumor. So it uses high frequency ultrasound, and the way it behaves is when it has a robotic head that is moved into the abdomen of the patient, not over the abdomen of the patient, and there is a water bath that is placed on top of the patient. This is also done under general anesthesia. So the robotic head is maneuvered so that it goes into the water bath and on the patient's abdomen. And now that has an ultrasound probe attached to it. So now we should be able to see the lesion through the water bath with the ultrasound probe for us to then plan the actual treatment. So in patients who are good candidates, it works well. And the other advantage is they have almost no pain when they wake up, and then they're able to go home the same day. But it's still in the early stages of use, in clinical use, and there's a lot that we're learning. We've only treated about 12 patients with histotripsy so far, even though we've had it for about more than 6 months now. So it's a selective technology that I use depending on the size and location of the tumor. The other limitation is also you cannot treat lesions which are more than 14 centimeters deep from skin to target. So the beam cannot penetrate more than that. So those are some of just a quick nutshell about histotripsy. So as I mentioned, the reason I prefer IRE in HEHE is the propensity of these lesions to be close to vascular structures or propagating along them, and the fact that it does not damage any of the vessels. Of course, with the needle, you can definitely cause vascular injury if we are not careful in placing it. It can still cause a bleed. It can still cause pseudoaneurysm. So all of that are still on the table. But when it's placed properly and safely, the actual technology is safe near critical structures. And secondly, the healing mechanism is different with IRE, which is the reason why I use that in patients with HEHE and not microwave or cryo.
Thank you. Question for Dr. Robinson. And there's kind of a combination of a few questions bundled together here. We have quite a few questions wondering, a patient comes in with EHE in the liver.
I lost the audio, sorry.
In the liver and maybe elsewhere in their body. And then there's questions about, we just learned about a number of different techniques that can be used to treat the liver surgically. How do we fit that into the decision tree of watch and wait versus electing one of these, ablation, transplant? Like what, Dr. Robinson, what's your sort of calculus when you're seeing patients, or what should we be thinking about when to elect one of these procedures versus just seeing what happens?
Yeah, so thank you. That's a great question, and thanks for bundling and appropriately. So I would say that one of the things when you are a sarcoma medical oncologist, you quickly realize no one's an island, right? And we are very multimodal in our approach to care as well as our decision making. So if I have a person coming with EHE, if we're lucky enough that that person comes in with solitary lesion, I may immediately reach out to my interventional radiology or surgical colleagues to discuss which given the focal nature after the staging, whose modality might be better, and offer the visits with those colleagues, and ultimately have the patient make an informed decision with moving forward. If the patient comes in with, as they often do, with extensive disease, we in addition to seeing me as a medical oncologist, we do have all the other colleagues weigh in for an opinion, and to Dr. Thiels's point, judging the biology of the disease. And so, in his series, I had a great patient that I think served as an example of the benefit of the multimodal approach, in that she came in with liver involved as well as pulmonary involved disease. And so we started off with after consensus discussion, because her disease was really focused in the right lobe, and she had an isolated lesion or two in the left lobe. And we ultimately chose to kind of, assess the biology of the disease, as Dr. Thiels noted, by doing an active surveillance. I don't like to say nothing, I call it active surveillance. And so, we did short interval scans for her, at the 3-month point. and really tried to gauge the rate of growth. We saw very little change in the lung nodules, and similarly in the liver confined disease, there was a slow rate of growth, but we weren't seeing new lesions appear. And she ended up going to extended hepatectomy, where now one of our colleagues who retired, Dr. Nagorny, took out the right lobe, and they actually worked in conjunction with the interventional radiologist. So not only did this patient have surgery, they had intra-op ablation of the two nodules in the what would have been the remnant left lobe. And we followed that patient since, and she has done very, very well. Her lung disease has hardly changed whatsoever, and we're now more than 10 years out. And so I think it really shows the importance of not just coming to see the medical oncologist, but getting the input of our multidisciplinary partners, because sometimes one modality, multiple, a couple in combination, and ultimately tailor the approach to each patient. I hope that answered the question sufficiently.
Excellent, thank you. Question for Dr. Thiels. A lot of patients will go to whatever center they're closest to, and we know from EHE it's a rare disease, and some centers see a lot more patients than others. And we get a lot of questions from the audience in these sessions about, well, when I talk to my doctors, I didn't hear about these options. What is the ability for patients who might be seeing a physician who's not an EHE expert to reach out to a place like the Mayo Clinic or other centers that see a lot of EHE patients for a second opinion, or to possibly transfer their care? Is that something that is viable, and what does that look like?
Yeah, absolutely. A great question. I think it's always a good option to consider. I think, it's something where it's not that means transitioning your care or doing even all of your care or even any of your care at that center. I think a lot of times, at least here, we actually try to not deliver a lot of the care here when possible. There's experts like Dr. Raj locally who can do things probably just as well or maybe even better than we can, and where it makes more sense to have a procedure where you can recover at home. So I think one thing I'll say is that getting a second opinion somewhere doesn't mean transitioning your care. And it doesn't mean that your home team isn't well equipped and can maybe even do things just as well or better. And I think we tend to encourage that. Maybe it's the distance that people travel here, but I think it's kind of the Mayo Clinic approach in that we're just providing another opinion, and we encourage patients to go back to their home physicians who are oftentimes providing great opinions. But I do think sometimes it does make sense. And it's not that there is one person here, necessarily that's the person to see, but it's after I point out, it's just the ability to see kind of multiple people who do these things a lot. I think a lot of centers have one person who does one of the things a lot. But I think sometimes in a bigger sarcoma center like a Mayo or a bigger place like that, you have kind of an expert in every specialty who sees EHE quite often. And that's where we can get kind of the different approaches. And sometimes it's actually not even coming up with a different or new treatment. It's just providing reassurance. But sometimes we are, because of that kind of combined approach, able to kind of come up with something slightly different. I think the hardest thing I think is to figure out when to do that. And I think, what we find is, if things are stable and have been stable for a long period of time, then probably not necessarily a time where it makes as much sense to come here. If things are, early on, that's a good time, I think, or if things are progressing, but hopefully not before it gets too late. Or for things like transplant, I think it's a good time too. Unfortunately, we don't have the ability to do virtual visits across state lines. The government doesn't allow us to do that anymore. I did it a lot during COVID. What we still do, though, is we review patients before they come here. We review their imaging, we request their imaging. We kind of try to review as much as possible information to try to avoid a patient coming here where we don't have something where we can at least provide a meaningful opinion for. So we turn people away, but not because of, because we don't want to treat them, but because we're trying to sometimes prevent them from spending the money to travel here and things like that for something where we can't do better than their local team, because their local team is providing excellent care. So that's where we do review in the background. And sometimes we'll even do a video visit with surgeons as a travel planning visit. It doesn't work as much for medical oncology, but for surgery, we'll do a visit to kind of plan ahead so you know what to expect when you come here. Hey, we maybe are thinking about a surgery or an ablation or something like that. And there we will do a video visit in advance of the trip here. Hope that kind of answers that.
Very well, thank you. And final question for
David, if I might just throw in,
please,
just to reassure that patient and the question, I have patients go for second opinion. So even though I'm here at what Dr. Thiels has pointed out would be a high volume center, I still encourage second opinions as well, especially if the patient has questions or doubts. And often we even help facilitate the second opinion.
Excellent. Final question for Dr. Raj. And this is kind of bundling a couple questions as well, but if you try one of these surgical intervention approaches and it doesn't work, can you try another one?
Yes. You mean from an ablative world or after resection?
Yeah, it could be any of these. Could you start with an ablation? Could that lead to a resection? Could it ultimately lead to a transplant? Or can you try one and then try something else later?
So most of them, there are patients who I don't think would be ideal for IRE, and some of them which have come to me have gone on to get a resection, given the size and the location. But if they fit the adequate location size criteria, and with the more cases we've treated, we're more comfortable in taking on patients even with sizes in the past that I would not have been comfortable treating, having seen the response that we've seen. The one advantage that ablation offers is preservation of the liver, because even with resection, I've had few patients, including the last one we treated, was somebody who had a resection and then it recurred in the remaining liver. Same with transplant. I've treated one patient who had recurrence in a transplanted liver. So what ablation gives you is a method to kind of push the potentially push transplant as much as long as possible. Some of my transplant colleagues that I worked with and I'm still in touch with say that, while it is an option, we prefer, if these patients are younger, to see how far we could push it and try to get them more time. So given the nature of this disease, we feel like if we can ablate and control it and, work with their oncologist and, maintain them so that we can use it, push it as long as we can. As far as other modalities, there is only one patient where I've used microwave for one lesion alone because I could not get there with the multiple needles with IRE. But pretty much every other patient, all the lesions, we've treated them with IRE. And that was by design, like for the reason that I mentioned earlier.
Excellent. Well, thank you, panel.